Hello, I'm Dr. Greg Potone, and today I'm going to talk to you about psychiatric issues and management in Parkinson's disease. So I don't have any relevant financial relationships with commercial interests regarding the content of this discussion today. I am a consultant for several pharmaceutical companies. The objectives of the talk today will be to become familiar with the presentation of psychiatric issues in Parkinson's disease. Then we'll discuss how the physical and biological aspects of Parkinson's might be associated with psychiatric issues. And finally, I'll recommend some strategies to help manage psychiatric issues in Parkinson's. So I think it's first important to discuss how psychiatric issues might be associated with Parkinson's disease. So when you've heard about Parkinson's disease in the past, most discussions have probably centered around the fact that it's a disease of the midbrain. Specifically, it seems to affect the substantia nigra pars compacta. And this is important because it has dopamine cells that are important for movement. And so you can see here in the slide on the top that there's a dark band of cells. These are dopamine containing cells in the substantia nigra pars compacta that as they die off, they're no longer able to produce dopamine. And you can see that condition, we call it Parkinson's there in the lower slide with the pale substantia nigra. When this happens, people begin to have trouble moving. They have slowed movement, which we call bradykinesia, and then at least one other symptom of either resting tremor or rigidity of their musculature. Later, as the disease advances, people have trouble with walking and balance and many other movement problems. But that's really not the entire story. So the same process, the propagation of misfolded alpha-synuclein that we call Lewy bodies, is affecting other parts of the brain. And when that happens, it causes other symptoms besides movement problems. And so we call these the extranigral aspects of Parkinson's disease. And at this point, they're fairly well recognized. Now, importantly, some of these symptoms may happen even before you develop the movement symptoms that define and are responsible for the diagnosis of Parkinson's disease, while others might develop much later in the disease course, like cognitive impairment or visual hallucinations. And some are selective. They affect some people, but not others. And so in some cases, psychiatric problems, whether it's depression, anxiety, hallucinations, may actually be a part of the disease process of Parkinson's. At other times, they may be risk factors or just comorbid happening along with the Parkinson's disease itself. And so here's what Parkinson's disease might look like over the course of one patient's life. So let me orient you to the slide. The horizontal line at the bottom, the x-axis, time 0 represents the time at which Parkinson's is diagnosed because the movement disorder symptoms are present. So it turns out that in most people, the disease is present for many years and probably decades before the time of movement symptom onset. And that's really important. Now, once you have movement symptoms, they are continuously present from that point on, usually progressing in severity, but managed by the medications we give you. And then you'll see other symptoms may start to emerge as the disease goes on. People might experience fatigue or mild cognitive impairment. Some people might have urinary symptoms or disturbance of their autonomic nervous system, which causes orthostatic hypotension or low blood pressure, along with other problems. Some people might hallucinate, not everyone, but some may. And you can see as we move from left to right, meaning from shorter disease duration to longer, people tend to accumulate more of these symptoms, okay? Now, what you might notice is that to the left of 0, you see some odd things like constipation, RBD, which stands for REM sleep behavior disorder, excessive daytime somnolence, loss of sense of smell, and depression and anxiety should be there. And that means that some people may have these as early symptoms of Parkinson's disease or early risk factors. In this case, we actually know that some of them are related to the same disease process. And so let me show you how things like depression and anxiety might be related to Parkinson's disease. So again, here's a figure where the x-axis, that horizontal line, time 0 represents the time of Parkinson's disease motor symptom onset, okay? Everything to the left of the 0, which I've colored red, and everything to the right of the 0 is after Parkinson's onset. Everything in the red is before. And so this is the time of first depressive disorder onset in people who are diagnosed with Parkinson's. And this is sort of a review of many studies put together in this figure. And so this represents, hundreds of patient lives. And so you can see that some people suffer from depression before they're diagnosed, some at the time of diagnosis, and some afterward. And the relationship to the Parkinson's may differ. Some of these may just be depressive disorders that were there and have nothing to do with the Parkinson's. And some may have actually been due to early loss of dopamine or serotonin due to the same disease process, the accumulation of misfolded alpha-synuclein and Lewy bodies. Same thing with anxiety, except for you'll notice that the left tail, everything to the left of the 0 there in red, tends to go out even a little further. And that's because we actually recognize an association between early anxiety and risk of Parkinson's for at least 2 decades, pretty consistently. And then the other important thing to know is that on average, people with Parkinson's tend to have more anxiety and depression than people without Parkinson's. So clearly, the biology of Parkinson's, the same disease process, is increasing the prevalence of both of these problems. So again, I'll talk more about this, but I just wanted to set the stage that anxiety, depression, and many psychiatric syndromes are directly associated with the disease pathology. Okay. So now I'm going to break this up, and we're going to do anxiety and depression first, and then we'll do psychosis and other behavioral disturbances second. So anxiety and Parkinson's disease can present in many different ways, but most commonly, it'll be a sense of persistent worrying about everything, mundane things, or even acute panic. Sometimes with physical symptoms, people hyperventilate or feel numb around their mouth, have heart palpitations. Other people will ruminate and overthink things. Many people will have an inability to relax. They'll feel tense or restless, sometimes even pacing or wringing their hands. They'll be so anxious. Difficulty maintaining focus or concentrating, being indecisive because the anxiety is preoccupying them. Muscle tension and aches are very common because they can't relax. There's a tremor many times in people with Parkinson's, but the anxiety itself can often cause trembling or worsen the tremor of Parkinson's. Excessive sweating is a problem that you see in Parkinson's, but this can also be a manifestation of anxiety. And then loose stool, diarrhea, upset stomach can go along with chronic anxiety syndromes especially. And so both physical and mental symptoms can be present when someone has an anxiety disorder. Many people with Parkinson's will have this. At least half of people will have clinically significant anxiety symptoms. And then up to a third of people will have an anxiety disorder, which is a cluster of symptoms so severe that they cause dysfunction in day-to-day life. Okay, and we call that a disorder or a syndrome. And then when we surveyed and interviewed people with Parkinson's, we found that 42% rank anxiety as one of the top 3 unmet needs in the entire disease. That's any type of symptom. And so anxiety is a big target for people suffering from Parkinson's disease. Now, again, going back to this idea of some anxiety starts before Parkinson's is diagnosed and some starts after. Here's another figure that's from our personal data, patients that we interviewed, with time 0 being the onset of movement symptoms. Now, remember, I told you that the disease may actually be present and unrecognized in many people a decade or 2 before the movement symptoms begin. And you're having an accumulation of Lewy bodies and misfolded alpha-synuclein, but it's just not causing movement problems at that point. And so I've sort of color-coded this into 2 peaks, if you will, what we call a bimodal distribution. And if you look, you can see there's a gold peak and a burnt orange peak. And let's talk about what that gold peak may be. So in our research, in our center at Johns Hopkins, we found that people who had anxiety disorders in that gold peak had pretty typical anxiety disorders, meaning they had things like generalized anxiety disorder, social phobia, or panic disorder, things that you'll read about in the diagnostic and statistical manual, things that people without Parkinson's are diagnosed with. But what was really interesting is that if you follow those people from the point they were diagnosed onward, here's what you found. And this is just so we're clear. This is 3 different studies from 3 academic centers. So Mayo Clinic and Harvard. Actually, the first and third are from the same center. They're just 2 different studies. They're from Mayo. And what we found is that anxiety is a premotor symptom of Parkinson's disease in many cases. And so whether you assess the anxiety as a disorder using formal criteria, or just as a symptom, and in the case of this symptom survey here, it was the CRISP Crown Index here, or as a personality trait. Okay, so Bowers et al. Looked at the MMPI, which is a personality inventory, and they found that people who had an anxious personality, people who had anxiety symptoms, or people who had full anxiety disorders had almost a 2-fold greater risk of Parkinson's later in life. And this risk was conveyed for up to 20 years before the onset of motor symptoms. So clearly, in some people, anxiety is either an early symptom or a risk factor. And that's what's in that gold peak. Now let's flash back to this figure again. So if that's what's in this gold peak and might be directly associated with the disease, what's in this burnt orange peak? Well, when we looked, about 2/3 of these people who had the first anxiety disorder onset after they were diagnosed with Parkinson's, about 2/3 of them had anxiety associated with fluctuations or wearing off of their Parkinson's disease medications. And so I think you're all familiar with the idea that you take, let's say, carbidopa-levodopa, which is Sinemet. You take it, it's absorbed. Your motor symptoms get better. But as it wears off, they start to return. Now, ideally, you take another pill before that happens, and you really never experience that complete off. But as the disease goes on, this response curve becomes a little more brittle, and you might start to have some wearing off at the end of dose, or some people even have sudden, unpredictable wearing off where their motor symptoms come back. Well, some people, in addition to the motor symptoms coming back, have severe anxiety or even panic-like attacks during these wearing off or sudden off periods, okay? And what's really interesting is, you would intuitively think, well, this is related to dopamine, right? Dopamine comes into the body, you're fine. Dopamine leaves the body, and you're anxious. Well, just to be certain, there was a study done by Miracle et al. By Jay Nutt's group in the Oregon Health System where they actually gave dopamine infusions. And they found that as they started the infusion, which is that dark box is when the infusion is running, both people with Parkinson's and an observer who knew them well, a spouse, family member, or caregiver found that anxiety got better as they infused dopamine. And when they stopped the infusion, you can see it about 11 there on the chart, the anxiety started to go back up again. And so clearly they showed this direct association between dopamine levels given by infusion and anxiety levels. And so not only is movement affected by dopamine in some people, so is anxiety. And so that could potentially explain the wearing off or on-off fluctuation anxiety that we see in that burnt orange curve. And it makes sense because it starts after Parkinson's is diagnosed and after dopamine medications are introduced. Now, the other type of anxiety that's maybe not specific to Parkinson's, but common in Parkinson's is this fear of falling. And fear of falling, once gait and balance are affected by the disease, is very common. We looked at 22 studies in Parkinson's and represented over 1,000 patients, and we found that 51.5% of them experienced a fear of falling. And this fear of falling was so profound that people would often avoid leaving the house. They would avoid activities, really become more disabled than they were simply because of the fear. And in addition, the fear caused them to freeze more frequently, to have what's called turn hesitation when they tried to turn when walking. They walked slower on average than people with the same severity of motor impairment. The ones with the fear and the ones without the fear, everything else being held the same, walked slower. And they had greater postural impairment. So clearly, this is another symptom that needs to be addressed so that people can do their best in managing the disease. Now, I've told you about some ways anxiety affects the disease. So what can you do to help treat the anxiety? Well, one thing is work with your neurologist to optimize motor function in addressing any motor fluctuations you might experience. So if you're having end of dose wearing off and you're having anxiety, fixing that might not only improve your movement, it may decrease your anxiety. Okay, so that's the first thing is optimize motor function, have a conversation with your neurologist. Now, unfortunately, there hasn't been a lot of study of medication treatments for anxiety specifically in people with Parkinson's. We have good treatments that have been tested in people without Parkinson's, but we haven't really done studies in Parkinson's using medications. And so for the most part, we use antidepressants, and they seem to help a little bit for certain types of anxiety. And we use benzodiazepines, things like clonazepam or lorazepam for short-term help with anxiety. Ideally, you don't want to use those long-term. So there are things, they just need to be a little better vetted in Parkinson's for safety and efficacy. So hopefully more on that in the years to come. But right now we use the same things we use in the general population, and they help a little bit. Now, one thing we have tested specifically in Parkinson's that does help, especially for things like fear of falling and other anxieties that lead to avoidance of activity, is cognitive behavioral therapy. And this has now got several high-quality studies supporting its use specifically in Parkinson's disease. Another one that's got an emerging literature supporting its use in Parkinson's is mindfulness-based therapies. So this is a little different than cognitive behavioral therapy, but it does the same thing. It takes sort of our thoughts and emotions and helps us better separate them so that we can deal with them individually. Okay, so that any distorted thoughts are sort of recognized and then either ignored or addressed in a more productive way. Neuromodulation of various types is an emerging option, but again, none of these neuromodulation studies, whether it be from repetitive magnetic stimulation, RTMS, or transcranial direct current stimulation or deep brain stimulation, have specifically looked at anxiety as a primary outcome. They've always been either neglected to look at anxiety outcomes or had it as a secondary outcome. And so while these might be promising, further study is required, but I think that's another avenue to be hopeful for with anxiety. depression in Parkinson's is, again, very common. In many cases, it might actually be part of the same disease process, meaning that the same mechanism that's causing the overall disease is causing the low mood. And in many people, it's very evident. They're sad, they feel down and blue, but in an equal number of people, they don't feel frankly sad. However, they'll have a decreased interest or take less pleasure in the things they usually enjoy. So even if someone is denying being sad, they still might have depression. And that's really important because you'll notice that they've withdrawn from many of the activities that they usually do, or if they do participate, let's say people push them to, they enjoy it much less. Depression is not just a change in mood. It's physical. It can have physical or what we call neurovegetative symptoms. People can have a change in appetite. Most classically, it's loss of appetite, although some people tend to eat for comfort. Same thing with sleep. There can be a change in sleep patterns, and most classically, it's insomnia, trouble sleeping or not sleeping enough. But in some people, it's sleeping too much. I've seen people sleep 15, 16 hours a day, sleeping away most of the day. There can be movement abnormalities because of the depression. So some people will develop what we call a speech latency as a complication of psychomotor retardation. So you'll be speaking with them and you ask a question and you can almost count 1,000, 2, 1,000, and there's a delay in their speech. We call this psychomotor retardation for the profoundly depressed. Decreased energy. Parkinson's is already a very fatiguing disease, but depression can lower energy further. Feeling worthless or inappropriately guilty is another clear sign of depression. Having trouble concentrating or being indecisive, and then recurrent thoughts of death or suicidal ideation. If you see these in a loved one, you need to get the doctors involved right away. This, just like the disease, is often a biological syndrome that isn't going to get better if they just try harder. It needs treatment to fully improve. Now, how impactful, is depression and Parkinson's disease? Well, the biggest study to date, ongoing study to date in Parkinson's, called the Parkinson's Outcome Project, run by the Parkinson's Foundation, took a longitudinal look at which treatments produce the best health outcomes in Parkinson's disease. And when they looked at depression compared to movement problems, compared to all the other symptoms of Parkinson's, they found that the impact of depression on quality of life in Parkinson's is almost twice that of the movement symptoms. And so depression is a huge target in Parkinson's because it accounts for a greater burden adversely affecting quality of life. And so it also can affect the movement symptoms. And so when you look at someone with Parkinson's disease who has the same level of disability, of physical disability, the same severity of movement symptoms, and then one is depressed and one isn't, and then you follow them over time, the depressed person physically functions less well than the person who is not depressed with the same level of movement symptoms. And so this is a paper that we published a few years ago where we looked longitudinally across 6 years of our patients at Hopkins and found how depression affects their level of disability. And so we use something called the Northwestern Disability Scale, which looks at things that we call activities of daily living, things like brushing your teeth, eating, walking, speaking, getting dressed. So very fundamental things to daily life. And we measured them, you can see there on the left on the y-axis, with higher scores being more functional and lower scores being more disabled. Okay, time 1 to 4 represents the 6-year period. We have visits. We had 4 visits over that span of the patients, okay, in our longitudinal study. And the dashed red line, the SD, is symptomatically depressed. These are people who are actively depressed. The green solid line is people who are never depressed. And the people with the dotted blue line are people who have remitted depression. Either it was treated into remission or it spontaneously remitted. And what you can see is that red line, the people who are actively depressed are functioning less well, are more disabled than either the people who've never been depressed over the 6-year span or the people who had depression that remitted. And so what's important is if you're depressed, you're much more disabled. But the good news is at any point in this 6-year period that you treat the depression to remission or that the depression resolves, you function better physically. And that's in addition to, not suffering the burden of depression itself. And so, again, what are the things that you can do to help with depression and anxiety? We mentioned that your doctors are going to have potentially some medication options, but what should you be doing? Well, one thing that we know is important is not letting yourself become isolated and lonely. You have to stay connected. And so it turns out that loneliness and social isolation are the equivalent of smoking, high blood pressure, and obesity in terms of how adversely they affect your health. So these are not fluffy, throwaway recommendations. As a strategy for your health and well-being in Parkinson's disease to combat depression and anxiety specifically, you need to stay socially connected to other people, whether that's friends and family or groups, doesn't matter. Okay. Stay connected, stay engaged. So as people retire, especially, they tend to not have structured activity. So work, your occupation is a structured activity. Volunteering is a structured activity. Participating in a group activity, whether it's a community association that you belong to, or maybe you have a music interest group or a current events group, doesn't matter. Structured activities are exercise for the mind, and they've shown to benefit you in terms of your mood and decreasing the risk of depression and anxiety. Sleep is centrally important. Poor sleep is both a risk factor for and a symptom of depression and anxiety. So look, you're going to be challenged as you age, and you're going to be especially challenged as you age with Parkinson's to get a consistently good night's sleep. So what I tell patients to do is to focus on giving themselves an 8-hour sleep opportunity. And, you're going to sleep well some nights and not so well other nights, but you need your behavior, your action needs to be to provide yourself with this 8-hour sleep opportunity where there's nothing conflicting with that opportunity for sleep. Okay. And then the cards fall where they may, and there's things that can help, but your job is just to ensure that 8-hour sleep opportunity. And then finally, exercise. So exercise is important for maintaining mental health. Okay. It lifts mood, it decreases stress and tension. So it helps depression and anxiety. And oh, by the way, it might be the only currently available disease modifying treatment in Parkinson's, meaning a treatment that actually decreases the progression or slows the progression of the disease. Okay. And it decreases the day-to-day physical symptoms. But here I'm telling you that it also helps the mental symptoms of Parkinson's disease. And, just so you hear this, everybody's beating the exercise drum, right? But let me show you concretely how important it is for mental health. So in the case of aerobic exercise, my group is doing a systematic review, and we found 18 articles where aerobic exercise, this is sort of the exercise that gets your blood pumping and your lungs burning, improved attention, processing speed, reaction time, and executive function and language skills in people with Parkinson's. And this was most commonly performed on a treadmill or just walking outside, a stationary bike. So you could swim, whatever you enjoy that gets the blood pumping is considered a aerobic exercise. Now, this guy is running. So if you like that, you can do that, but it could be almost anything that's under the label of aerobic exercise. Okay. And it's been shown definitively now within people with Parkinson's, studies that took place in Parkinson's, to reduce the severity of depression. What about other types of exercise? Well, there hasn't been as much study, but we found 3 articles specifically in Parkinson's that found a benefit of what's called resistance training on cognition in Parkinson's disease. And so here's a woman who's lifting weights, but you can do just body weight exercises or resistance bands, elastic bands that provide resistance. And specifically, these studies found that it improved performance in measures of executive function, that's our ability to organize, sequence, and plan, and attention in Parkinson's. And so by the way, it also improved balance and gait in Parkinson's. So again, I just wanted to put these in here so that you wouldn't think that this was a soft recommendation. There's now, over 20 something studies that have specifically looked at different types of exercise in Parkinson's and shown very specific benefit. Now, I want to talk just a little bit about other types of psychiatric issues. And it's, before I talk about these, it's important for me to tell you that just because I'm talking about these today doesn't mean that everybody's going to get these symptoms or have these problems. In fact, these class of problems, the majority of people probably don't get. Okay. In fact, in impulse control disorders, which is one of the ones I'll talk about, maybe happens in 15% of people with Parkinson's. So this is more giving you the knowledge so that if you do notice something like this, you'll bring it to the doctor's attention. Okay. And you'll also know that you're not alone, that other people have these symptoms, no matter how bizarre or distressing they may seem. So let's talk first about what psychosis means. Okay. So you hear this term psychosis, psychotic symptoms. What does it mean? Well, for most people with Parkinson's, the lion's share of psychotic symptoms will be visual hallucinations, okay? And a hallucination is a false sensory perception. In this case, it's a visual perception and the absence of external stimuli. So you look in the corner of your room, you see a little redheaded girl and nothing's there. Sometimes, though, it can be a little more tenuous than that, where it's a misperception of an actual stimuli, and we call that an illusion. So you see a man standing in the corner of your room, you flip on the light and there's a coat rack there, not a man, but a coat rack. And so you've misperceived it. That's an illusion. Okay. And now that can happen with other senses too. So an auditory hallucination might be that air is flowing through your air conditioner vent, and instead of the flow of air, you hear Gregorian chant. That would be an auditory illusion. Okay. You can also hear things that other people don't hear, and that would be an auditory hallucination. Another type of hallucination that people with Parkinson's especially seem to experience is seeing something out of the corner of their eye that seems to move, and they look and it's not there. So it's only in the periphery of their vision. It could be on either side. We call this a passage hallucination. Okay. That happens. If it happens, most people aren't distressed by it, but let your doctors know. And then sense of presence hallucination. This has been described in other diseases, but seems to be especially common in Parkinson's. And it's this sense or feeling or idea of someone close by. For instance, one of my patients told me they're doing the dishes and they feel as if someone walked up behind them. They turn around and look and no one's there. So it's not that they saw anything. They just felt as if someone was standing near them. And it doesn't have to be a person. So I had another patient who told me that his dog, who had been dead for 2 years, always used to sit at his feet. And he said sometimes when he was watching TV, he would get the distinct feeling that his dog was sitting near his feet, so much so that he'd look down, but the dog wasn't there. So the sense of presence, okay? And then some people, and this is actually fortunately pretty rare in Parkinson's, will get what's called delusions, which are false, fixed, idiosyncratic beliefs. So sometimes these delusions are paranoid in nature, sometimes they're bizarre, but again, they're not that common. And when they happen, they definitely should be treated, okay, because they can be very distressing both to the patient and to their family members. But when we say psychosis, it's usually some mix of these symptoms that I just mentioned, and most commonly it's visual hallucinations. Again, this won't happen to everyone with Parkinson's, but if it does, don't panic. Let your doctors know. So when you have one of these symptoms, these psychotic symptoms, like I said, there's medications that can help, but let me give you an idea of what the management strategy is. So first of all, if this is the first time you've had a hallucination or the first time you've developed delusions, your doctors are going to look for an underlying medical illness, because many times if you recognize and treat this underlying medical problem, it might be an infection or a metabolic disturbance, the psychotic symptoms will go away, sometimes forever, sometimes just for a while. But oftentimes they're triggered by something that can be treatable and the symptoms will resolve. Okay. Sometimes if you've had a medication change, either an increase or an addition, this is classic with pain medications of certain types or anticholinergic medications. They tend to cause hallucinations in people with Parkinson's. And so just discontinuing those medications can oftentimes make the hallucinations or psychotic symptoms go away. Okay. Sometimes, though, as the disease progresses and your medications to treat Parkinson's, the dopamine medications increase, they can actually interact, the disease progression and the dopamine medications can interact in a way that causes you to hallucinate. When this happens, sometimes you'll rebalance, and maybe you'll accept a little less motor control in order to make the hallucinations go away. And so sometimes we'll find that we're adjusting medications to treat Parkinson's in order to address psychosis. And then sometimes, even if you've done all these things, the hallucinations or delusional beliefs will persist, and we'll actually use an antipsychotic medication. There's really only 3 types that are suitable for use in Parkinson's. There is Seroquel, clozapine, and pimavanserin. Seroquel's generic name is quetiapine. And so these are used in low doses to good effect with Parkinson's if you need them. Sometimes cholinesterase inhibitor medications like rivastigmine or donepezil are useful. These are also the same medications we use for cognitive impairment in Parkinson's. They can help decrease the risk of psychotic symptoms. And then there's non-pharmacologic strategies like keeping your house well lit at night. This makes visual hallucinations less likely. If you see a hallucination, if you look away and look back and look away, sometimes you can distinguish that it's not real by doing that visual technique. Just educating people about the fact that these may happen and what they are helps. Discussing it both with patients and the caregivers can help. So again, that's one thing that may happen to some people with Parkinson's. And then there's something called impulse control disorders, okay? And these are sort of an assortment of behaviors that are performed repetitively, excessively, and importantly, with a lack of self-control to an extent that interferes with daily functioning, and they get you in trouble, okay? So some of these are normal things that we all do, but it's the extent to which they're performed that causes them to be problematic. They're most often associated with dopamine agonist medications like pramipexole, rapinol, very occasionally with the Nupro patch, probably not as often, and sometimes other dopamine replacement therapies. The most common are hypersexuality, compulsive shopping, pathological gambling, and some people binge eat. So these are the most common, but it could be almost any activity, okay? Here's that list of the big 4 that are reported commonly, but it can be other activities. Now, here's a problem that sort of can occur along with impulse control disorders. Some people almost get addicted to their dopamine medications. This is actually pretty rare. Maybe 3 to 4% of people with Parkinson's will actually start taking their Parkinson's medications more than is needed to control their motor symptoms, almost as if they get a rush out of them. And when this happens, you'll see that it sort of co-occurs with impulse control disorders because now their system is loaded up with dopamine. They might be psychotic because they're overdosing themselves with dopamine, which has a relationship to hallucinations. And they can even have panic attacks. They might be hyper. And again, when this does happen, most often the neurologist will, be refilling your prescriptions before they're due. And like I said, it's almost like a drug addiction. Unfortunately, it's rare, but I wanted to mention it today just so that you would know if it was happening, what to do, and to bring it to your doctor's attention. And then there's this funny little behavior that can sometimes happen in Parkinson's called punding. And this is sort of a repetitive, purposeless behaviors. characterized by intense preoccupation with specific items or activities. So, people might do things again and again and again. So one patient I had, she'd rearrange her kitchen all day, moving things from one drawer to the other. And initially, she and her husband both thought she genuinely was rearranging the kitchen. But when it went on and on and on and just didn't stop, and there really seemed to be no rhyme or reason to the rearrangement, we discovered it was punding. Most often, punding is driven by dopamine and advanced, progressing disease. And so we, lowered her dopamine a little bit, and it helped to reduce the behaviors. Hobbyism is sort of in the same spectrum as punding. It's just a little more structured. So this might be a higher level, more complex, repetitive behavior, like excessive internet use or reading or artwork or working on projects. It might almost look like ADHD, attention deficit hyperactivity disorder. People might, start multiple projects and do them repetitively, but never complete the activity. So this, if you think anything like this is going on, it can be very nuanced, but bring it to the attention of your doctor. Okay. So I know this has been a lot of ground to cover, but the reason that this is important is that these behaviors in particular, you might be embarrassed about or not think they're related to the Parkinson's. And so if you make this connection, you'll at least know which doctor to talk with about this. And so, like I mentioned, treating impulse control behaviors, it's really a withdrawal reduction or tighter control of dopamine medications. And most often for impulse control disorders, it's dopamine agonist medications. Treating it really hasn't been successful with other medications. It's more the reduction of dopamine medications, but people have tried amantadine and a medication called naltrexone. There's really not good evidence that they work, but I just wanted to let you know there's been research into this. And then there is a suggestion that cognitive behavioral therapy may help with some of these impulse control disorders. And then for things like pathological gambling, the addiction model where you use a 12-step group like Gamblers Anonymous and involve family and caregiver and restricting access to financial accounts can be very important for damage mitigation and protecting financial assets. So again, I don't want to get too far into the weeds with the specific treatments, but I wanted to let you know that there are things that help, but more importantly, recognizing these and bringing them to the attention of your doctor is the first step. And so I'll stop there. And then we'll have a question and answer session where we can talk about any issues that you might have concerns about or questions or clarifications. Thank you for your time.